Hello, everyone. Welcome in. Thank you so much for being here today and tuning into the IFG webinar series. We would love to know where you're tuning in from today by using the chat. Baltimore. Welcome, Sheila. Thanks for being here. Arizona. Awesome. Well, I'm going to kick things off. Hello, everyone. Welcome to the Ensure Fitness Group webinar series. I'm Shannon with IFG, and I'm super excited to be your co-host today. If you're new to Ensure Fitness Group, we're a leading provider of comprehensive liability insurance for fitness professionals across the United States. Our coverage extends to personal trainers and a wide range of other fitness modalities, but we don't stop at insurance. We also offer exclusive member benefits like discounts, continuing education opportunities, and more, all available through our member portal. To explore everything we have to offer, visit insurefitness.com. Just a couple of housekeeping tips. A reminder that today's webinar will be 60 minutes and it is being recorded. The recording will be emailed to everyone tomorrow, so be on the lookout for that. We also encourage you to ask questions, so feel free to use the chat or the question and answer feature, and we will be monitoring both throughout. We'll also reserve the last 10 minutes for a quick Q&A. Now we can jump in. The topic of today's webinar is brain-based recovery, training clients after joint replacement. Please join me in welcoming our hosts, Pat Marques and Dr. Grove Higgins, two trailblazers in neurological-based training and recovery. Pat, a Z Health Master Trainer and NSCA-CPT, discovered the power of neurological training while working with wounded soldiers post-Army retirement, now helping clients from chronic pain sufferers to Olympic athletes, improving performance and reducing pain. Dr. Grove, with nearly 30 years in healthcare, specializes in solving complex chronic pain and repetitive motion injuries through medical-based corrective exercise, co-founding a not-for-profit that supported over 2,500 injured military members alongside Pat. We're thrilled to have them share their innovative approaches to optimizing recovery and performance with us today. Please welcome Pat and Dr. Grove, and thank you for tuning into the IFG webinar series.
All right. Well, thank you very much. It's a pleasure to be here. I'm Dr. Grove Higgins. Pat, when he gets on, he'll introduce himself a little bit more as well. But this is exciting for us. We love working with the post-rehab medical fitness world because this is where things from a long-term perspective really happen. I mean, when you think about what we're talking about today with joint replacement, over 200 million Americans will undergo a joint replacement this year alone. And what happens after PT determines whether or not this individual just survives and recovers and survives, or thrives and returns back to life, returns to play, as we're putting it here. And so being able to share some of that with you is a great opportunity and a great pleasure and honor for us to be able to do that. And I need to update my CV. I mean, it's definitely more than 30 years now. It's getting on to 40 years in this post-medical rehab area, and a lot has changed. Let's go through just a quick agenda on what we're going to be going through. In the beginning here, we just want to go through some of the generalities of what requires a joint replacement, what leads up to that, and then also what to expect from their recovery, and then some of the myths that you might hear, because there's a lot out there. And if you just search the internet, there's a lot of, unfortunately, bad advice because it just doesn't have good context and it's not necessarily based on good data and such. And so the people that you're working with, whether they're potentially going to have a joint replacement or they've had one, are probably full a lot of these myths that you can be somewhat prepared to explain away. And then hopefully you'll become more confident in your approach to these individuals that you'll work with, because we'll all work with somebody that's had a joint replacement, and the threshold for that's getting younger and younger all the time. So not just old people with replaced joints, but younger people, because joints sometimes get damaged early and need replacement. And then on top of that is we're going through the templates for post PT joint replacement exercise based therapies. Hopefully you'll also start to learn what can be done to help these individuals before the joint replacement, but even before that, maybe even to potentially help prevent needing a joint replacement in the future, because you can do better assessment, you can help train them better from a mobility standpoint, strength standpoint, motor control standpoint, and such. And we're going to go through some things that we have learned and is in the literature as well about how to better train and strengthen and make these individuals, again, go from just recovery to thriving in their normal lives and returning back to things like playing pickleball as a 70-year-old, which we've had plenty of those. And then we'll give you some resources beyond that. So I myself, before going on, I got passionate in this. I started working in physical therapy in the rehab world specifically, more when I was a late teen into my early 20s. And in that time, that was the beginning of hip replacements and such like that. And we've seen a huge change in the technology, in the materials, and in the techniques for rehabilitation and such, that really have made joint replacement a miracle for those that need it. And in the beginning, it was a very long, slow process. And now they have you up the same day, going to the restroom. That always surprises people. They get up out of the big surgery where they've replaced a big joint like the hip joint, and they're like, I need to go to the bathroom. And they're like, great, get up, go. And they're like, really? I can? And that's their first introduction back into life with a replaced joint. Oftentimes, not so much for the knee. The knee is a little bit more tricky, but the hip is very, very successful. And we can look by these annual rates of joint replacements in 2025. Knee replacements have actually started to eclipse hip replacements in the numbers of them. Hips are a much more robust joint. They just don't degenerate quite as rapidly as knees do. And the technology that used to be superior in the hip is now starting to emerge in the knee, where you have better assessments, better creation of custom knee joint appliances that allow the surgeons to get in there and out of there very quickly and replace it with a knee joint that probably operated better than the knee joint did, not just before it was damaged, but before there was any hint of damage to that knee, just from a biomechanics standpoint. And so we're starting to see knees in our clinic more and more all the time versus hips. And then shoulders are becoming better as well. That's a relative latecomer to the joint replacement menu of services that they provide. And then there's also joint replacements in the hand and in the foot and the ankle as well, but we're not going to get into those today. But a lot of these same principles that we're going to be talking about today can be applied to any body part in general. All right. And then you could look at that average age for joint replacements, and you can see that, the average age is actually quite low. It's into the 60s. And shoulders, the rehab tends to be a lot harder, and the surgery is a lot more involved. And so they tend to wait a lot longer before they do that. But that number is coming down. I've seen individuals in their 20s with shoulder joint replacements, usually because of trauma and such, but it is coming. All right. So what does the typical joint replacement look like? So before we even get to surgery, we have an individual who has movement disorder, right? You look at the most individuals, most of the predominant cause is inflammatory arthritis, osteoarthritis type of conditions. So this is a long, slow process for most people who are going to receive a joint replacement. So there is movement dysfunction, which if you are a really good practitioner in what you do, you're looking for that, and you're helping to improve that on all of your clients across the board, no matter what. And so you can prolong the longevity of that joint for a long time, and even for a lifetime, if you are good at identifying those movement disorders and then improving their strength and activation, and long term just giving them better fitness in general. And then, but there are other options, other things that happen like trauma, injuries, and such that add to increasing the speed of especially osteoarthritic conditions that then necessitate a joint replacement. But then a joint replacement is recommended. There's too much damage to the joint. It's not recovering like it should. And the surgeon and the patient decide this is the course to go through. They go through the pre-op, they go through the operation. Immediately, they're starting rehabilitation in the hospital, day one of the joint replacement. Shoulder, it takes a little bit longer to start that process, but for knees and hips especially, it's day one. Within the first hour that they're waking up, they're doing things, they're moving the joint, they're moving, they're getting up and walking and doing things like that. So we break it down into phases, and this is a typical phase of PT, post-surgical PT. So within that first couple of weeks, it's very protected motions. Again, the hip is less so, but the strides are not as long. They're not loading it or anything like that. And the knee may have bracing applied to it externally. And then after, in the 3 to 8 week range, then we go into the protected motion and muscle activation phase. And this is where you're doing more range of motion type of activities. You're doing things like quad sets, where you're just contracting muscles and relocating those muscles right off the bat, which could be done in the protected motion phase as well. And you're starting to get load into the joint, body weight as well as external loads, and progressing as quickly as the patient is able to. And then in 4 to 12 weeks, now we're jumping up in loads, we're jumping up in ranges of motion, intentional ranges of motion. And then eventually the return to play phase in 3 to 6 months. Again, hips are faster than knees by a long shot. And after that 6 months, there's some level of return to play. We see individuals who have hip replacements back to golf within 3 months, and which is huge for them. Usually a little bit longer for pickleball and things like that, where it's a little bit more dynamic and fast movement type of things, a little more coordination and such. But we see them coming back pretty quickly. And then the most common post-joint replacement issues, they've had pain for up to 2 years prior to this, asymmetrical motion and strength loss. So here's kind of a question for you. If a person has been demonstrating pain and bad movement and poor strength leading up, does that have an impact on their recovery? The answer to that is, of course, yes. And they're going to carry over some of that bad movement patterning and inability to activate muscles and such like that for quite a while. And there's only so much time in physical therapy that insurance will allow. So most of the time, patients that are released from PT either meet a time limit or a limit of maximum medical improvement, because they keep hitting plateaus. And so then insurance says they're done. And they don't have that option anymore within their insurance. They could always pay for it out of cash, but a lot of people don't have that. So by the time they come to you, there's still a lot of work to be done to improve them, and again, return them to play in such a way that it looks like life before the joint replacement, and the need for the joint replacement. Okay, so now let's get into a little bit of some replacement basics and myths. Let's do a little myth busting. So, general joint replacement myth. Joint replacements don't last. I'll need another operation eventually. The research, yes, that's true, depending on how old the person is when they first get their first one. But joint replacements are lasting longer and longer. It used to be that within anywhere from 5 to 10 years, you could start to see degradation of the joint, and then within 15 years, you'd be getting another joint replacement. Joint replacements are going 15, 20 years. We had an individual that had to have finally a replacement after over 20 years on a joint that was actually recalled within a year after it was put into his body. But they're not going to, of course, take out one that's working until it fails. But it didn't fail for almost 20 years before he needed it. So there you go. It's a long recovery following joint replacement. Well, you saw the numbers that we put up there. Anywhere from 3 to 6 months, they're returning to play, and so the recovery seems long, but that's a light years faster than it ever used to be. The question is it up to the level of performance that the person wants and needs for life? That could be the long part of this equation. Artificial joints are only for people with arthritis, and that is a big no. There are traumas, of course. There's infections that eat away at the joint and damage the structure of the joint and require joint replacements and such like that. And then lastly, after you complete physical therapy, you're as good as you'll get. Well, we've already kind of hit that one. There's so much more improvement that the person can have and that you can be an agent of when that time comes. Now, specific ones. Knee joint. After knee joint replacement, you cannot bend the knee fully. Well, it is common within the first 30 days to get up to 120 to 135 degrees of range of motion back, and in the literature, so you can get that range of motion back quite well. The question is of course how much dysfunction is going in to the joint replacement, and that oftentimes is the determiner whether or not that person is going to need more time to get their range of motion back or not. And then some people develop scar tissue, and they'll need some form of aggressive manual therapy, or sometimes what they'll do is do what's called manipulation under anesthesia, and we've seen that many times. You should not do twisting or lateral movements after knee replacement. Well, that's not true either. The way that these are designed, that there's the normal knee joint, unreplaced knee joint, the tibia has the ability to internally and externally rotate in order to access that lock home mechanism when the knee is straight, and to internally rotate when the knee bends and flexes, like going upstairs and such like that. And so bending and twisting is a normal part of the range of motion of a healthy knee, and they've made sure that the new knees are built very similarly. And in fact, again, better in a lot of cases. And you cannot drive after knee replacement. Outside of taking medication that would prevent you from driving a car just because it's a narcotic or something like that, as long as pain is not a limiting factor, then you can return to driving usually within days after a knee replacement, definitely after a week. Hip and joint replacement myths: you won't be able to walk for weeks. No, you're back to playing golf within 3 months. And they have you up literally the same day to go take yourself to the restroom, do your activities of daily living, dress yourself, and things like that. Those with severe hip arthritis cannot get a hip replacement. No, that's the most common reason for a hip replacement is arthritis. So it does not take trauma to necessitate that. And then you can't flex your hip farther than 90 degrees or adduct across the midline. And again, the way that these are built now, they are much better. Now, in the very beginning, you do have limited ranges of motion because they're waiting for those muscles to reactivate to, just like the normal joint, protect the joint in its ranges of motion, so that way it does not cause damage to itself through its normal ranges of motion. Somebody that is very hypermobile can dislocate things like shoulders and other joints and such like that. You don't want that around a joint that's been replaced. And right afterwards, you're cutting through muscles. Those muscles are slow sometimes to wake back up neuromuscularly. And so that's once that is established, when those muscles begin to reactivate and self-protect the joint again, the knee can do, or the hip in this case, can do just about anything that it did before. Shoulder joint replacements. After a shoulder joint replacement, you can't lift or reach overhead. Well, that's the whole point to getting a shoulder replacement, is so that way you can reach up overhead. That's usually one of the big signs that they start to look at for a joint replacement for the shoulder, is when you can't do things like wash your hair, reach up overhead. You know, your life is limited to the shoulders and below. And so the whole point to having a shoulder joint replacement is so that way you can reach overhead and you regain that range of motion. With the shoulder replacement, you shouldn't lift over 200 pounds. Again, with the current technology, that is not the case. What those upper limits look like and such are somewhat ambiguous depending on the research that you're looking at. Most surgeons like you to protect their work, so they're going to try to limit things. And you should always listen to the surgeon and the guidance that they're giving you when you're working with that kind of a client, of course. But I worked with not too long ago a veteran in his 30s. He'd been injured multiple times, both shoulders, reverse replacement, which is what you see in the image on the screen here, where they take the ball in the socket and turn it around in the joint, essentially, and it's very stable. And he was doing overhead Olympic lifts, and with a lot more than 20 pounds. And then after a shoulder replacement, you can't play sports with repetitive overhead movements. Again, the research is a little ambiguous on that. You have some research that's really showing a lot of return to play in that sense, and others that are restricting that because they don't want to see that overhead component overused, and that's of course where there's the most risk. But with the current technology, more and more individuals are returning to play and things like tennis and overhead activities very quickly and very successfully. So it really depends on who you're working with, what the surgeon's limitations are. Of course, you should always work within that. And then what is the comfort level of that patient in doing those activities? Because if you put them in a situation where they are feeling at risk, then they're not going to give you their best. They're going to hold back, and their movement patterns will be defensive, and that could lead them to injury and dysfunction, which you don't want to contribute to. You want to work within their comfort levels and build up their confidence, and in that confidence, then return them back to the level of life that they're able to return to comfortably, and that makes them feel good. You don't want to violate their trust. All right, from here, we're going to move on to the neurocentric part, and that is where Coach Pat Marques is going to take over.
Thanks, Doc.
A little bit about yourself.
All right. This is my second career, basically. I was in the Army for 20 years. I was a D1 athlete, and then spent most of my time in Special Forces in the Army, and met this guy working with wounded, ill, and injured soldiers here in Colorado back about almost 15 years ago now. And that's when I kind of fell in love with helping through exercise, and what I like to call exercise therapy, because I'm a trainer, right? Through exercise, and get people out of pain and help them move better. And specifically using a brain-based approach. So I'm a Z Health master trainer. Z Health Performance Solutions is a education company with a brain-based curriculum. Won't go into that a lot, but we've got their website at the end if you want to check that out. But that's where I got my education in brain-based way of training, and it's about 600 hours of that. So what we do here at our clinic, and then all the courses that we build for online stuff, is take people through a brain-based approach or neurocentric approach to whatever the issue may be. In this case, joint replacement. We've also got a stroke recovery fitness course. And what does a brain-based approach mean? That just simply means you're looking at the client through the lens of their nervous system. And a couple big reasons for that. Number one, your nervous system is the governing system of the body. It runs everything, right? Your digestion of food, right? Your movement, right? Your brain sends a signal to move. You don't move without your brain telling you to do so. But everything else you don't think about, hormone distribution, et cetera, right? The nervous system runs everything. So if we are able to look at a person and whatever issue they're coming for, whether it be anything between fitness or movement dysfunction or pain, through that lens of their nervous system, then we can get really fast results because the nervous system acts very quickly. Another big important concept is that your brain's number one job is survival, not being awesome. So performance, so awesome pain-free movement, right? Performance is a gift that your brain gives you when it feels good about everything. This conceptual framework here, this kind of input, processing, output model, is how you can think about this in a framework that's easy to understand. So we're all receiving, down there lower left, see the input go into the brain, right? We're all receiving gigabytes of data to the brain all the time. 3 big bins: external, your 5 senses, telling your brain what's going on outside the body; internal, gut, heart, lungs, right? And I include this vestibular system in this, your inner ear, which orients us towards gravity. And then proprioception, right? If you've got an exercise science degree, kinesiology degree, or you've been through a trainer certification, you probably heard the word proprioception. Proprio means self, ception means sense. So your self sense, kind of your body positioning system, right? Or where are you in time and space? Best way to think about this is it is your brain's 3D map of you for movement. Now, that map can be super accurate and clear, or we can have some cloudy spots in it, right? And that usually after injuries, after disuse or misuse, repetitive motion injuries, after surgeries, right? We have a lack of proprioception in a given area. And we'll talk a lot about that later. So all this input has to go to the brain. Your brain has to process it. It's doing that super fast, and it's doing it all the time. And it's going to compare all the input with other things that have happened to you that like, so if you're throwing a ball, every time you go throw a ball, your brain's going through a process of every time you throw a ball, right? And comparing it to what's going on right now. It's going to make a decision. And that decision is going to result in an output. Outputs are along a spectrum, right? So the brain is going to send an output of pain or no pain, somewhere in the middle, right? Stiff, flexible, weak, strong. You can see it all there. It's weird to think about pain as an output from the brain, but it 100% is. 21st century brain science and pain science. Pain is an action signal that your brain generates. It is not a signal from an area that hurts to the brain. See, other way around, right? The brain sends pain there because it is getting a threat signal from that area. Won't go into a bunch of neuroanatomy, but we don't have pain receptors, but we do have threat receptors. And depending on the level of threat that's sent to the brain, again, the input, right, from an area, then if the brain deems that unsafe enough, threatening enough, it's going to send a signal of pain. And this is how the body really works. And so a brain-based approach takes advantage of the system, and we focus a lot, we're going to talk about these coming up next, are the inputs that you can change so that the brain processes that input as safer, and you get better movement, right? Stronger, more flexible, less or no pain. And I noticed on some of the chat, we got a lot of people who have already had joint replacements, and some of them very recent. So it's not great that you have joint replacement, but it's great that you're listening to this and you're going to hopefully get some ideas from things. So this is the template that we use for post-PT, but like Dr. Grove said, this is also the template I use for before surgery, right? Prehab in a sense, the same things. So 5 things we want to be able to assess and reassess well. We're going to talk about each one of these. We'll have a slide or 2 on each one to discuss what it is, what we mean by it, and then some examples. Sensory input to the area, motor control of the area, isometrics, super important. and then more neurocentric dynamic exercise. So assess and reassess. We've all heard the term, if you're not assessing, you're guessing, right? There's two really aspects of assess and reassess. There's baseline assessments. So you want to be able to measure range of motion, right? And the primary motions around that joint, right? You can also assess for functional or activities of daily life. For instance, someone has had a shoulder replacement and they still can't put dishes up in the cabinet, that kind of thing, right? So I use those all the time with clients. Like, what is it you need to be able to do that you can't do right now? And then any sport requirements, golf, pickleball, tennis, throwing a javelin, whatever your sport is, right? But then we also want to be able to assess in session. We're going to show you some examples of that. And we often use range of motion, but we also use muscle testing a lot. And that can show you right then and there whether an exercise or a drill is threatening to your brain, or if your brain feels safe about it. We'll talk about that here in a bit. For strength, you want to be able to assess that with joint replacement as well. We use a lot of manual muscle testing. We've also got dynamometers that we use to check force output. And really what you think about this is it strength or is it the muscle firing enough, right? So there can be atrophy and so to the muscle and actual weakness. But a lot of times though, it's just the muscle's not firing because the brain feels threat from that area. And so again, it starts to process threat. And so it acts like a governor car engine and doesn't give full force output. So we've seen people get a lot stronger literally in a few seconds by doing a drill that the brain really wanted and needed. And all of a sudden, boom, muscles are firing again. You'll see examples of that here coming up. So an example of assessing knee replacement for range of motion, right? Some ways that you can do this are lying knee flexion, kind of see, and the range of motion we always want to see is what the pain-free range of motion is. So that's key. Again, I talked about pain. It's an action signal from the brain, and it can be a learned skill, unfortunately, if you keep pushing into pain. Understand that discomfort is not pain. Pain is, discomfort you can kind of breathe through and get through, right? If you're doing a bunch of body weight squats and you're feeling the discomfort of your quads burning, that's different than sharp pain. We all kind of know the difference, but we're talking about sharp pain that you can't just breathe through, right? That's what we don't want to go into with any of these range of motion assessments. So we like to see some active range of motion, right? Lying flexion, lying extension, can they lock the knee out? And then tibial rotation for knees in this example. Dr. Grove talked about that twisting and bending that needs to happen. Tibial rotation is really important with that. And if we have a lack of tibial rotation, that will affect the biomechanics of the knee in a negative way. So that tibial rotation is super important. For strength and muscle testing, if you're used to, feel comfortable with, and everybody states different, so what you can and can't do with this. But for most people, most trainers, you can do manual muscle testing. It's basically just an isometric, right? You're blocking movement and the person's trying to move. Client initiates it, you meet the force, right? And then try to push them out of it slightly, obviously not pushing into any pain. You don't touch the muscle that they're actually trying to do. And you always want to test both sides because you want to see the relative difference. The example I always give with this is that you can touch clients when you spot them, right? If they're squatting at a barbell or bench press or doing things like that, right? This isn't manual therapy at all. This is just muscle testing. Super important to do, and it's a great assess, reassess, right? Somebody said shoulder replacement, you assess their middle deltoid, right? It's weak, they can't hold it. You do a drill and boom, after that, they can hold it. That's a great example of assess and reassess in session. So these are the kind of things that we assess from a baseline, though, what the range of motion is, and then some strength muscle testing. And do this for hip and knee, or a hip and shoulder as well. Sensory input is the second big neurocentric area we want to focus on. Our primary goal with sensory input is to improve proprioception. So we'll talk a little bit more on the movement aspect of proprioception when we talk motor control, right? But this is, remember proprioception is your brain's 3D map for movement. And moving a joint, because of receptors in the muscles and the tendons and the joint capsule, send a signal back to the brain about that joint and map that joint better. But sensory input, right, like touch type stuff, right, also does that. It allows the brain to see that area better. In the next slide, we'll go exactly how that happens, right? This then informs the motor cortex for better movement, right? And it improves the spatial orientation for that area and can even get pain reduction. So the how list there are the different things that are available to most trainers. So some skin stimulation, right? Just kind of rubbing with the knuckles, using a brush. That would be one way to drive some stimulation to an area. Vibration tools are great. So I mean like mini massagers that vibrate in certain ways. Vibration is a very novel input to the brain. And so you have nerve endings that sense vibration specifically. That's their job, is sensing vibration. And because it's something we don't get in a normal daily life a lot of, it's very novel to the brain. It can be a very powerful tool. If you're using a percussion gun and you want to give vibration input, you need to set it on low and just barely touch it to the skin, not actually press in. If you're pressing in, then you're getting to the pressure input down there, right? So baroreceptors, right, are that sense pressure pushing in. But any kind of wraps like knee wraps, sleeves, elbow sleeves, those kind of things, that's pressure input. That's why these devices work. It's all neurology, really. And if you're familiar with floss wraps, kind of the rubber strips that you wrap around a joint and you keep on for a minute or two and then take them off, again, you're given that pressure input. Temperature, hot and cold packs, it is doing some things at a physiological level. At the local tissue. If you put hot on an area, there's more blood flow to that area. If you put cold on an area, there's more analgesic effect or a numbing effect. But the really big reason it helps is because that is sensory input to the brain about that area. And then skin stretch. Skin's your biggest organ in your body. So if we're using kinesiology tape, like the picture shows there, that is some decompression of the skin. Completely neurological reason for, if I'm sure many of you have used kinesiology tape, put it on your knee and your knee feels better all of a sudden. It doesn't work 100% of the time. All of these things are very individual. You have to test and retest them. We'll talk about that here in a second after this next slide. So sensory input, right? This is your brain with the top taken off. You see that blue sliver? That's your motor control area. Purple sliver is the parietal lobe. That says, or the front of the parietal lobe, which is the somatosensory area. Then you see the cutouts on each side, right? The cross section. Notice there are areas, right, associated in your brain with every piece of real estate in your body. So if I was doing the small shoulder circles, right, the motor control area is sending the signal to make that motion happen. The fact that I'm doing that motion and moving that joint is sending a signal back to the somatosensory area for the shoulder, right? So you see the purple dot there and the blue dot. And then that sensory input of the movement is feeding forward to the motor control area, giving it better information to move better with a clearer map, like fog's being taken off the map. Now we start doing sensory input like hot and cold or percussion, vibration, kinesiology tape, the pressure input. We're just increasing that much more, that sensory input, and mapping that area better. So that is how we use that to improve movement around the area, either less pain, better range of motion, both. So an example of the assessing if it's good or bad, right? The first picture we see, okay, this is Mary's pain-free range of motion on knee extension. She's short, a full knee extension. We apply some sensory input. In that case, it's a little ball that vibrates, right? Like the massage tools that you can use. And then we reassess, and she gets more range of motion. If she may not get more range of motion also, because maybe that input is not either the brain doesn't feel safe about it, or it's not the kind of sensory input that's going to map good enough for it. That's why we have these different types that we would check, right? But more often than not, they literally just yesterday in the clinic, I used vibration on a guy who got more knee extension, exactly like this, right? It wasn't even a joint replacement, other knee damage. So you can also assess movements like lunging or squatting. How far can you go before pain? Then apply the sensory input, and then see if you can lunge a little bit farther without pain, right? So that's how you're going to assess and reassess the types of sensory input, right? Where you're applying it, the muscles that cross the joint in the case of a joint replacement, or any areas of pain. Those are the best places to use. And you can use that before, during exercise. You can use it between sets. And what's great about sensory input is your clients can be doing this at home quite a bit to regain mapping of an area. When we talk motor control training, now we're taking a joint through a full pain-free range of motion. The goal here is, again, improve proprioception of that joint. So in the joint receptors, the muscle spindles, right, and the Golgi tendon organs, when you move a joint, right, all these receptors are sending a signal back to the brain. Remember, there was probably mechanoreceptor damage from possibly in any of the injuries before the joint replacement, and then also the surgery itself, because they've got to cut into you. So these things can build back, right? But we have to do something specific to do that. And taking joint through a full range of motion, right, that is pain-free is what does that. And that proprioceptive map, if it's not clear, it's going to affect negatively flexibility, coordination, and strength. So example for the shoulder, right? You guys could all do this right now, right? If we do a quick assessment of no pain, right? Nobody going in pain. You don't have to do this if you don't want to. But if I bring my arm up, right, got 90 degrees, I'm just going to do some shoulder internal rotation, right? Well, a little stuck there at the bottom right now. You can kind of test where you're at, right? And then we'll do one motor control drill, what we call a camshaft. You're going to take your arm, have it straight out. I'll turn to the side. Think about your scapula. Again, you're not moving in any pain. Elevate your scapula, move it forward, depress it, move it down, and then move it straight back. Move that into a circular motion in those 4 spots, up, forward, down, and back. And then you can reverse the direction. Just do 3 or 4 reps and then retest your range of motion. So I gained quite a bit from that, right? So we see this all the time. We don't do a lot of reps of this, but we do try to have people do this a lot throughout the day. So figure 8s there, a more complex nonlinear movement can be really important for motor control drills. And of course, we've got tons of these. Okay, my personal favorite, isometric strength training. So we want to get a muscular contraction without shortening or lengthening of the muscle, right? It can improve strength and control. Isometrics are the least neurologically threatening form of strength training. The brain feels very safe doing isometrics because there isn't any movement, and you can work towards maximal force production and kind of joint packing, right? Whereas maximal force production with any kind of resistance training, you know, that can get you need spotters and et cetera, right? So this really trains force production. And it activates some different areas in the brain. Some of the prefrontal cortex areas that actually plan movement light up more during isometrics than in dynamic movement. They are great for pain reduction as well. Important thing to understand that I learned from Doc Grove is that synovial fluid is a non-Newtonian fluid, right? So the more force that gets put through that fluid, the more viscous it gets, the stronger it gets. So isometrics are a great way to do this to increase joint stabilization. These are a non-negotiable for my joint replacement clients. We're definitely doing isometrics. An example of it for hips, right? This is one I will often show right off the bat, is just taking a yoga block, and in 3 different positions, you just move in that yoga block, you're doing hip adduction isometrics, and then taking a yoga strap and then pressing out, right? So we're getting the adductors and the abductors of the hips, working some really good isometrics there. The thing with isometrics that you are working with from a parameter standpoint is the effort level. So 100% effort would be, giving it all you've got, right? And then how long you're doing the isometric. Those 2 things, effort and time, are inversely proportional. So 100% level of effort, 4 to 6 seconds max. If we had a dynamometer on you, we'd see the force bleeding off after 5, 6 seconds. If you're doing about 75%, you can get 20, 30 seconds of maintaining a force. If you're at 25 to 50% of an isometric contraction, now you can do that for 1, 2, 3, even up to maybe 5 minutes. We like to do different joint angle positions too. You get stronger throughout your range of motion, even if you do isometrics at one angle, but you get strongest at that angle. So we like to give different joint angles, like we show in these 3 pictures. There's also ways to do open chain isometrics. All right. Lastly, neurodynamic exercise. This is what everyone's a little bit more familiar with. You're lunging, you're squatting, you're doing the kind of things that you normally do as a trainer, right? We like to do a lot of varying of the movement planes and of the stimulus to build a library of prior movements, right? And we like to associate vision a lot. So a couple quick examples. This is what we call the lunge compass. So for the knees, we're going to have people lunging out in different positions, right? It all around, so that they have got this library of different positions where they've stepped out into. Obviously, you're not going to go to a deep lunge when you're lunging with a lunging leg to the rear, right? But these give a great library of prior movements for dynamic movement. Here's another example with the hips. We also use the lunge compass with the hips, and we'll do visually guided. So there are apps you can get out there that will give random stimulus with like arrows. So as you can see here, we got an arrow up and left. It's a 45-degree lunge to the left. Straight to the left, it's a side lunge, right? Or you could easily be doing this by pointing in different directions, right? Or having Post-it notes on the ground and their number, and you call out 1 and they look and they have to see, right? That visually guided is very important, because that's really how we move. Our vision tells us where we're moving and what we're doing, and then we execute a movement. So tying vision in is a very important aspect of neurocentric training. This is just kind of a roll up here on the key points there about assessing, about sensory input, motor control, isometrics, and then neurocentric dynamic exercise. And we're getting right to question time. We'd like to throw this out there. This is also in the PDF that Shannon will send you. If anybody's interested, 50% off we have a 20-hour joint replacement fitness specialist course. So you got a coupon code there. And there's a lot of great courses on MedFit. And depending on what your certification, you can see down there, you can get CEUs for that. But we wanted to offer this to you guys for jumping in today. And last slide, resources. But again, you're going to see all this as Shannon sends the emails out for everything. So I'm going to stop the share. We can hit some questions.
Awesome. Thank you so much. Let's kick off the question and answer portion. So like Dr. Grove said, use the question and answer feature, or I can also moderate the chat, whatever works best for you.
All right. I don't see any questions in the Q&A right now, or there's nope.
I did see a question pop up. Is there a difference between hip replacement from arthritis versus hip fracture repair?
The big difference there, from arthritis, there's going to be a lot of movement dysfunction before before the assessment for a knee for the joint replacement occurs. And so the problem there is that they're coming into the joint replacement with a lot of dysfunction, a lot of neuromuscular patterning around a problem, versus trauma, which usually, if there's trauma, it's going to lead to a joint replacement fairly quickly. It may last for a while. He talks about his ACL after having a year of an ACL tear, having bad patterning that led to a limp that even though he rehabbed successfully, he still maintained, right? So even trauma can lead to that, but it depends on how long that trauma is there for. But usually trauma goes to the need for a joint replacement very quickly. So those people come out with less movement dysfunction initially, but they also might have soft tissue issues because of damage from whatever that was, car accident, things like that. So, rehab from arthritis typically is slower than from trauma, but not always.
Awesome. Question from Sandy. Let's see here. Can I go to the chiropractor and get my lower back cracked after hip replacement?
A couple of things. Not all doctors, and this is all doctors across the board, therapists across the board, trainers across the board, are made equally. Some have better competencies and are better qualified than others. So work with your chiropractor, talk to them about it, be comfortable with their answer to that. Because yes, you can, especially the pelvis, it can be adjusted very safely, but the technique or the force that's being used for the particular person with the particular problem that they have has to be modified sometimes. And if they are competent, they should be able to do it very safely. Yes.
Question from Diane. Can you please re-explain the synovial fluid response to isometric exercise?
Yeah, so non-Newtonian fluid, right? This is the analogy I use all the time because I saw this on YouTube, right? You can do home science experiments, right? I can't remember all. It's like cornstarch and
yes, cornstarch and water.
It's cornstarch and water, and you make a non-Newtonian fluid, and you fill a plastic kiddie pool up with that. And they'll take a bowling ball and they'll set it on top of that fluid and they'll slowly let it go. And that bowling ball is just going to slowly go into the fluid. And they slowly pull it out. And then they'll throw the bowling ball up and it will hit, because it's coming down with a bunch of force, it will hit. It was like it hit concrete. And then it slowly goes into the fluid, right? So as force increases in non-Newtonian fluid, the viscousness, the thickness, and the hardness, right, of that fluid increases significantly and immediately. And so by putting force through the joint with isometrics, and you're not moving the joint, so it's super safe for the brain, right? Obviously, you still don't want to move into pain. You're only using the effort level you can. You are creating that, or taking advantage of, I guess is a better way to say, that non-Newtonian aspect of synovial fluid.
The other aspect to that is that fluid is what contains the nutrients for the joint surface. So if the person, again, coming into this, if they're arthritic, they have a loose joint. The joint is not moving properly. It does not have the right tensions around it. They don't have good isometric control or strength around it. So that synovial fluid was not contacting the joint surface as well, feeding it properly so it could recover from exercise and just activities of daily living. So again, well before the person needed the joint replacement, if you're training them to move well and to have good strength, isometric strength being one of those things that we hardly ever train intentionally, you can help prevent a joint replacement just by taking advantage of what he just said.
There was a follow-up question from Diane. Is there synovial fluid in a replaced joint?
The answer is yes, there is, because the inside lining of the joint capsule produces synovial fluid. So even though they take off the joint surfaces, there is still fluid in there. It's not serving the same purpose anymore.
Perfect. Question from Blair. What do you mean specifically about improve the function of the areas outside the knee?
So what her question was is that she's rehabbing her knee as a Pilates instructor, if I remember correctly. And the body is an integrated system. So when one part of the system is damaged and degraded, it draws down on the whole system. But likewise, you flip that equation. If you have a problem with the knee and you improve the function of the hip, the spine, the ankle, it will feed back into that knee and help that knee. So you don't always have to go and scratch the itch in order to get the improvement that you're looking for. Improve the other areas that don't hurt, that you don't have limitations on, make those optimal, and it will help your rehab of your knee.
Awesome. Question from Sherry. I'm a CPT. If my client has progressed in strength/ROM beyond isometric PT and has limited time to exercise with me and solo, can we say she/he has graduated past that level and can skip those exercises in lieu of more progressed load moves instead? Can a joint eventually outgrow/outpace isometrics, making them a waste of time?
No. Okay, we often have this in the trainer world as this thought of people just do isometrics in rehab and stuff like that. 50 to 75% of my current strength training is isometrics. And I'm 57 and I'm getting stronger than ever. Right. So isometrics are a super powerful tool. I would not think of them as something that you grow out of. Not that you shouldn't, if there's limited time and they need to be able to do some things. We also want range of motion, right? Under load. Like we talk about deep split squats, right? Where you're taking that knee into a full range of motion and the hips going into full ranges of motion, things like that. That also important. But I like to be able to keep isometrics in. It doesn't have to be everything you're doing, right? But throughout the whole process of training at some level, because of their just huge bang for the buck for as far as increasing strength output and force output, because you will never be able to get as much force output under body weight or free weights or bands and things like that as you can produce in isometrics. You won't be able to.
And remember, like every other athletic quality, if you don't train it intentionally, you won't own it. And we should periodize all aspects of strength. So very dynamic and powerful movements to strength endurance and such like that. And so if you don't periodize it, you're going to lose some aspect of your athleticism if you don't train it intentionally.
Looks like there's a piggyback question from Diane. For instance, wall sitting holds, good isometric for quads and glutes.
What was the first part?
Wall sitting.
Oh, okay. Yes, yeah, that would be an example of an isometric. That's good. There's in our course we talk about a little bit in other webinars we've done. There's two kinds of isometrics: overcoming, right, and yielding. So overcoming isometrics means you're pushing against something that won't move or pulling against something that won't move, right? Using straps, right, or something to that effect. We like to use hip belts for the lower body. Hip belt secured down to something on the bottom rung of a squat rack or something like that that won't move on you and you're trying to drive up, right? Or if I had a barbell pushing into safety bars, that would be an overcoming. Yielding isometric is when you're fighting gravity. So halfway through a pull-up and you're holding it there, or a wall sit. They both have some slightly different aspects to them, but that is an example of an isometric that can be really good.
We had a question from David. How would this work for a movement pattern that has nerve damage? The nerve damage isn't in the area having the issue. The damage is at the spine. The movement pattern is the pec. Hopefully that makes sense.
All right, I'm seeing it here, so thanks.
Yeah, sorry about that.
This work for a movement prone that has nerve damage. Yeah, so isn't in the area having the issue. I'm not 100% sure of what you're asking, but of course, when there's nerve damage, you've got a potentially a sensory input problem, like he was talking about, as well as a motor output problem, or both. And so that can cause a couple of things when it's associated, like say the pec is associated with the shoulder. Even though it's not a nerve in the shoulder, it's a nerve to a muscle associated with the shoulder. Now you have a muscular imbalance that can then cause dysfunction there near the spine, but is affecting the pec. Okay, so yeah. So that nerve damage is going to cause you to have imbalance around that joint associated with that nerve to the muscle. So yeah, you have to be aware of that. Find ways to maybe stimulate that area, and if it's not stimulatable because it's so damaged that it is that it's degraded, then you've got to just be careful as the trainer to make sure that you have good compensation patterns put into place as you're training that, and don't let that weakness become an injury.
Perfect. We have 2 more questions. From Rhonda, we obviously train both sides of the body equally under normal circumstances, but do you still spend an equal amount of time using this brain-based programming for both sides?
In a lot of what we have in our course for joint replacement, we do have doing both sides for a couple of reasons. The first reason is it gives both you as the trainer and the client a understanding of, oh, my left side, whatever's going on, shoulder, hip, knee, right? They can see and feel how much different it is from, say, the right side. And then as time goes on, they feel that difference, lessening and lessening to become more even. So it helps. 2, every time you do, and people have probably heard about this, how if say you have a broken arm and it's in a cast, you should still exercise the other arm. And if you exercise the other arm, when you get that cast off, you'll have retained more muscle mass and strength in the casted arm, right? That is a real thing, right? That's a real thing. So we want to take advantage of that by also training the other side, because you get a crossover effect to the other side of the body. Thirdly, the way we didn't have a slide for this in this presentation, but it's important to understand left versus right on the human body. So if I go to reach with my left hand for a cup of coffee, the right side motor control area is actually sending that signal. But the signal to go grab that cup of coffee is actually only 10% of the neural signal. Right? It crosses over in the brainstem to make that happen. The other 90%-ish, it's not exactly 1090, but it's close. The other 90-ish% of the neural signal, when I go to grab a cup of coffee with my left hand, is sending down my entire right side of my body to stabilize this right side of my body so I don't fall over. And so we get that cross stimulation for stability on one side and voluntary movement on the other side, stability on this side, voluntary movement on this side, right? When we're training both sides. So those are the 3 reasons why we do like to train both sides.
Awesome. Last question from Sherry. This webinar was content rich and expertly delivered by our presenters. Is today's session approved for any CE, example, ACE or NASM?
I know through MedFit, they've gone out and gotten some CEUs for some of our courses. Yes.
Yeah. In fact, if I can do a
quick screen share again.
Screen share again. Though ACE, I can't read which one that one is. Yep. ISSA and NASM, those all those 4 are CEUs. There.
Awesome. Perfect. Well, we're going to go ahead and wrap up our webinar today. Thank you so much, Pat and Dr. Grove, for sharing your knowledge with us. And thank you so much, everyone, for tuning into the IFG webinar series. Just a reminder that the recording as well as the PDF slides will be sent out by tomorrow via email. So please be on the lookout for that. And thank you so much. Hope everyone has a wonderful rest of their day.
Thanks, guys.
Thank you.